In.
Thank you, Kaylee. Good afternoon, everyone. I'm Kim Haskin. I work with Legacy Family Hospice as their clinical director. A little bit about me, I'm an RN. I have been a nurse almost 15 years, with almost all of that being in hospice care. So it's something that's near and dear to my heart, and very often out in the community, although hospice has now been around for about 40 years, there's still just such a strong stigma around what hospice is and a lot of misconceptions out there. So we're going to briefly touch on a little bit of that today and help provide some clarity and understanding around what hospice is. Again, if you have any questions, just feel free to put those in the chat for Kaylee, and then we'll also address some questions at the end. So hospice care, I'm sure most have been familiar with that term. At some point in their life, hospice is end of life health care for someone that has been diagnosed with a terminal illness. Let's see if we can, Kelly, can I move these out of my way, these little windows? Oh, there we go, perfect.
Yes.
Hospice is a program that's designed to provide end-of-life care and emotional support to the terminally ill. That can be in their home, a nursing home, assisted living, any home-like setting, so that they can focus on quality of life and comfort care, and family members can be active participants in that care. And again, as Kaylee mentioned earlier, hospice can be a very scary word. There's a major stigma around it. When people hear the word hospice, they often equate it with imminent death, which definitely does not have to be the case. Also, a lot of family faces guilt, whether it's to bring hospice up or to even be open to the idea of talking about hospice with their loved one. A lot of times they feel like they're giving up on their loved one or not saving them or doing enough for them, when it actually can be the total opposite, depending on the scenario. Hospice often relieves suffering and medical care burden on a loved one when they no longer wish to receive aggressive treatment, or maybe they're not a candidate for aggressive treatment. So once we're at that point, now we're focused on quality over quantity, just shifting that perspective to a new set of goals, where we're focused on that quality of life. Again, not how many days we might have left, but what we're doing with those days versus in and out of the ER, getting dehydrated and going and getting fluids every other day, and then dealing with symptoms because we've got fluid overload. Lots of different things. We can instead stay at home, be with our loved ones, or when we do leave the house, do something fun versus having to go to the hospital all the time. The primary goals of hospice, again, are for a patient to avoid hospitalization or that aggressive treatment when they choose to do so, to relieve pain and suffering in the terminally ill, and to help the patient and the family to understand what to expect. Not just with hospice overall, but throughout the entire journey, those expectations shift depending on where they're at in their hospice journey. We assist patients with their what we call ADLs, activities of daily living, which could be eating, brushing their teeth, getting up and going to the restroom, taking a shower. So we help with that and their personal hygiene. And then we assist the patient and family with end-of-life planning. So we have social workers that can help with DNR, which is do not resuscitate, advanced directives to direct their wishes in end-of-life care, all the way down to funeral home planning, burial plot planning, the actual funeral itself. Quite often our chaplain here at our hospice will be asked to actually do the funeral service for families. So we stay highly involved in that. And then again, to assist loved ones through their spiritual and bereavement journey as well. So how do we reach these goals of hospice? So first, hospice will educate the patient, caregivers, and facility staff on hospice philosophy and care. Often our patients or residents are, again, in nursing homes, assisted living facilities, group homes. So it's very important that we collaborate with the facility staff as well. Hospice is made up of an interdisciplinary team, starting with the patient, their family. We have a medical director who's a physician, nurses, home health aides, social workers, chaplains, and there's a few other options as well, volunteers, massage therapy, stuff like that. The interdisciplinary team collaborates with the patient or their caregivers to provide those comfort measures such as medications, massage therapy, pet therapy, companionship. So each of these team members have a different role, of course. So our hospice medical director is the physician who pretty much guides all of the care. He provides the orders that we need, the medications, and then general guidance on the hospice care to the team. Then the nurse monitors symptoms, educates the patient and family, and facilitates those needs of the patient and family. The home health aide, again, assists with the activities of daily living and personal hygiene. And then they work really closely with the nurse to report any changes or concerns. The hospice medical social worker, they're the ones that meet with the family to discuss those advanced directives, DNR, funeral planning, things like that. And then they also help facilitate difficult family dynamics or any unresolved issues within a family. And then the chaplain meets routinely to provide spiritual support, companionship, bereavement. If there's times that the loved one or patient is not spiritual or religious, the chaplain can simply provide companionship, play music for them, or the family has the right to decline that support as well. So who qualifies for hospice? Generally, when someone has a 6-month prognosis is when we should start talking about hospice care. Oftentimes these hospital physicians aren't real comfortable. Again, there's a stigma around hospice. So even now in 2024, we still see patients going back to the hospital over and over and over again. And even though they're verbalizing, I don't want to go to the hospital, I just want to stay home. Some doctors are still just really uncomfortable with opening that door and talking about hospice care. But once they are deemed to have about a 6-month prognosis is when we should start looking at that. And Medicare has criteria. So for each disease process, there's a specific set of guidelines that help us evaluate and determine if a person's eligible for hospice care. And death does not have to be imminent for someone to qualify. We've had patients that love to go to the casino, and so every Friday night their family would pick them up, take them to the casino, and they'd have a great time. You can still have great quality of life and be on hospice care. You don't have to be on your deathbed to receive the benefit. And then the other question that we get a lot is, well, what happens if they don't die at that 6-month mark? Hospice is not a time frame. It's not signing your death certificate or acceptance of your death certificate. It's general rules and guidelines. So Medicare often pays for the benefit for your loved one to have hospice care. And so we can't put someone on and keep them on for years and years. But once they meet that criteria that a physician has deemed they're terminally ill and they meet the criteria for that diagnosis, we can bring them on. And then it's hospice's job to monitor their decline. If we go 6 or 8 months and there has not been any decline at all, then it's our duty to discharge them from hospice, which does happen sometimes, and they graduate back to, the regular doctors and physicians that they've been seeing. So not a bad thing. That means they're too healthy for us and we got to kick them out. So that does happen sometimes. So when is it time to talk to our loved one about hospice? Again, very scary word. We don't want to offend anybody, make them feel like we're ready for them to die and we want them out of our lives. So when should we bring it up? When their doctors start recommending it is a good time. Not only to talk to your loved one about hospice, but to reach out to one and maybe have someone come out and have that discussion with you and your family about it. A big one that often families don't see these cues or really don't know what to do with is when your loved one begins verbalizing they don't want to go back to the hospital. They're tired of their treatments. It becomes more of a pain then it does good to go to their doctor's appointments or hospitals. So that's a big one. And of course, when someone's diagnosed with an incurable condition, is a good time to talk about it. Even if it's way too early for hospice care, it's never too early for a patient or family to understand what that means. Hospice may not be the right decision in that given moment, but it's important for them to understand their options so they can make a best informed decision when that time does come. What we see all the time is when a referral is made last minute and someone is imminent, the patient and family don't really have time to process what's going on. And the hospice doesn't have time to really give them the education and support that they deserve during that time. It's more of a rush, get the comfort meds on board. We're really tending to the patient, making sure they're comfortable, and it's really hard to take the time to step back and really educate that family. Several weeks or months is more ideal than just a couple of days of being on hospice care. That way, it doesn't feel like a whirlwind to the patient or family once that time does come. It also gives them a chance to really get to know their caregivers. One wonderful thing about hospice care that a lot of clinicians don't get in the hospital setting is we really become family with these people. We go to their funerals, we invite them back to memorial services every year, and we really connect with them really for a lifetime sometimes. So it's really important that that doesn't happen last minute for some. Sometimes we can't avoid it, but sometimes we can and really need to be looking way ahead when possible. Okay, so now who pays for hospice? Who's going to foot this bill? Medicare, most of our patients are of Medicare age, and Medicare covers 100% of the hospice benefit. We do unfortunately have some younger recipients, and in that case, most private insurances do have some sort of hospice benefit. And for those that don't, then in some cases, we also will accept patient pro bono. We'll go out and evaluate their needs and what we can do for them. And if it's a good fit, we'll take them pro bono. Then what does hospice provide? Outside of that clinical team, the interdisciplinary team, we're available 24/7 for urgent needs. So we tell all of our families, we are now your 911. And instead of rushing to the ER, calling 911, you call us, and we will have a nurse on the line within a minute or two and have someone at your door within that hour. And the time in between, we're triaging and talking to you and explaining what to do for your loved one should there be a crisis going on. Day or night, 24/7, we're always available to come out and make sure that your loved one is comfortable. We provide the medications that are related to that diagnosis and anything that's related to comfort. So whether that be pain, anxiety, inability to sleep, nausea, vomiting, diarrhea, constipation, anything that can be considered comfort medications, we will provide. And we have a pharmacy that will deliver those medications right to your door 24/7. We also provide DME, or durable medical equipment. So wheelchair, walker, bedside commode, hospital bed, a low air loss mattress to prevent bed sores or pressure ulcers. Anything that you might need in that realm, we will provide and also deliver to your door. And then something that I didn't get on the slide but is important is any of your disposable supplies as well. So gloves, wipes, adult diapers, briefs, any type of supply that you may need, we'll provide that as well and deliver it to you. And then some hospices provide other resources as well. They can vary from hospice to hospice. It's not a standard Medicare benefit, so each hospice kind of decides if they want to provide something extra or not and what that might be. But it could be anything from pet therapy, massage therapy, providing journals or videos for a loved one, providing a final wish, take them out to dinner, do something special for them type thing. So each hospice varies on what extra they provide. I wanted to share these resources. I thought about kind of getting into some, signs and symptoms of what the dying process looks like for most people. you know, beginning from when you're first referred to hospice until you kind of stop eating, start sleeping more, and then kind of what it looks like a week or two out from death, and then what it might look like a day or two, all the way down to hours. But I didn't want to get too deep into that during this presentation. However, I am happy to explain that if anybody has further questions. But I did want to provide some of these resources. Whoops, sorry about that. Let's get move this out of my way here. But it's from a lady named Barbara Carnes. These books have been in my life since I started my hospice career. Gosh, probably at least back to 2012. All of these little books, they're about a 10-minute read, and they are the most excellent resources for understanding hospice care, understanding what quality of life means in the end of life. And then this 11th hour, the little pink book, really goes down symptom by symptom. And if you see that your loved one is doing these things, this is kind of the time frame. If your loved one follows the normal trajectory, this is what we're looking at, whether that be months, weeks, days, hours. So wanted to give you guys this little resource. These books can be ordered on Amazon. Very, very good hospice resources. Again, hospice is an excellent resource that can provide comfort and quality at the end of life. It's very unfortunate that there are just so many people who don't get the opportunity to take advantage of that benefit. Medicare really doesn't allow people to pass away in the hospital like they used to. There's a lot of strict rules around that, and so it is getting better over the years. But unfortunately, we still have this philosophy of what we like to call treating a patient to death, where they're back in the hospital over and over again. And then instead of dying of a natural, normal, calm cause, they're dying acutely and abruptly in a hospital setting, you know, where they were going to probably pass away anyway within that same time frame. But now you've got family at the hospital bedside not understanding what's going on, not understanding why the doctors can't fix them this time. And really, it's not their fault. The clinicians just really failed to provide that understanding behind their loved one's body shutting down and what's happening. And so we're treating the normal dying process as an acute illness, and trying to fix it when there's nothing to really fix other than to give that patient some quality and comfort. So I wanted to give the hospice I work for, who I'm very proud of, a little bit of a plug at the end of this. The company I work for is called Legacy Family Hospice. We're all over the Oklahoma City metro area in all of the nursing homes, assisted living facilities, and private homes. And we're privately owned by Chris Hamilton and Holly Pankhurst. I've worked with Chris over the years. I think we've worked at every company together since 2012. She's very passionate about quality of care. And she and Holly both go above and beyond to provide additional resources and things that are not expected of a typical hospice company. Very passionate about that. So I'm very proud to be working for Legacy for sure. So I wanted to kind of share real quick our difference and what sets us apart. Earlier, I had mentioned that lots of hospices do a little bit different kind of extra things. Unfortunately, it's getting less and less as the years go on. I'm not really sure why that is. So you don't see a whole lot of hospices providing extra resources to families like they used to. But some of the things that we provide, number one, when a patient's dying, our philosophy is no one dies alone. And so if you have a loved one who is in a nursing home or assisted living facility, or even in a private home really, and you can't be there with that loved one, you need to go home and take a shower or sleep for a few hours, we will provide someone to sit at bedside with your loved one overnight until you can get back there the next day. Usually that's at the last day or two of life. Once we kind of see those symptoms are getting closer, we definitely make sure that they're never alone. We provide massage therapy. We have a masseuse on staff, and she will go out and provide massage to the patients. If they're having increased pain or anxiety or just feeling stiff, she'll go out and give them a massage as often as they need it. And then our little Jax, we're very proud of our pet therapy dog. He goes around to all of the facilities and just provides that emotional support and companionship to the residents of the facilities and our patients. And then we provide a legacy journal. So if a family wants to provide us with photos or stories, lifetime stories, however they want that journal to look like, whether it be their loved one directed and their, the history of their life, or if they want it to be about the most recent vacation they took, however they want that story to look like, they can provide us the details and the photos, and we will put that together in a really nice journal for their family. And then therapy dolls, we've discovered that a lot of our Alzheimer's patients and dementia patients, especially the women, really thrive to have something to take care of. As long as it's not interfering with their dignity, we're real careful about that it's not looked upon as a child or a toy. But we will provide dolls to some of our dementia patients, or even if they don't have dementia and would like one. And it really provides that companionship. They truly feel like it's their real newborn baby, and it's so cute to watch them carry it around and love on it and change their clothes, and show the baby off to all of their resident friends. So we provide that to all of our dementia patients that families want them to have one. And I will share this slide. It has our contact information, so I will share it with Kaylee. That way, if any of you guys would like any more information about this, I definitely am more than happy to share it with you guys. I'm going to look at the chat real quick and answer some questions.
Yes, we do have a few questions in the chat there. We have,
go ahead.
We have, is the diagnosis for hospice made by the physician or by the hospice provider? So that was pertaining back to your, in the beginning, that first or second slide.
That's a very good question. So oftentimes the diagnosis doesn't match what they're even referred to hospice for. Again, Medicare has a very strict criteria around what qualifies someone. And so the primary care physician, the ER doc, a cardiologist, anyone can send us that hospice referral. Or if your loved one is at home right now and they don't want to go back to the hospital to get that referral, then our medical director can also write the order for us to evaluate. But it's hospice that deems what that terminal illness is actually is, based on that criteria and what their medical history is. So, and in short, either one can give that diagnosis, but hospice is the one who quantifies that diagnosis to say, yes, they qualify for hospice, and this is going to be their primary hospice diagnosis.
So kind of playing off of that question, I had a private one come through. So can you choose, are you able to select a hospice of your choice for, say, your loved one? Or are you stuck, with one provider and they're not doing what you thought it would be? Could you switch or choose your own?
I am so glad you asked that question, and now we'll add it to my slide for future. This is a very important one. Everything is up to you. You're the boss. You have the right to choose your hospice. You have the right to choose which physician follows you on hospice, or not to have anyone follow and just have the medical director for that hospice become the primary, which is most often the case. You always have the right. And what we do see sometimes is some facilities prefer working with one hospice over the other for whatever reason. And I will recommend that you listen to that facility, their recommendations, because they're usually recommending based on quality. However, and by law, they have to offer two choices. And but that does not mean those are your only two choices. You can pick whoever you want. Sometimes with long-term care facilities, they do require contracts, not sometimes, all the time, between the facility and the hospice. But if you find a hospice that is really important to you, that you choose that one, that hospice can help advocate to get that contract in place. It takes about 30 minutes to get a contract put together with a facility. Sometimes they'll say, well, we're not contracted with them, they can't come in. That's a very easy fix between the administrators of the hospice and the facility, FYI. Good question. Oh, and can you switch if you're not happy with care? Absolutely, you can. So we have what we call Medicare hospice benefit periods. The first two are 90 days long, and then after that, they're 60 days long. And those are what we call our recertification periods to show Medicare that we can recertify them that are continuing to meet criteria. And you can transfer to another hospice one time within each benefit period. However, if heaven forbid you end up with two hospices that you're unhappy with in that short amount of time, you do have the right to revoke hospice, cancel them, and then have another hospice come in. It will just start you in the next, you'll lose a benefit period, which isn't the end of the world. It's just a little bit harder to get a hospice to pick you up if you've had revocations, whether that be because you didn't like your hospice or because you revoked and went to the hospital to seek aggressive treatment. It just becomes harder to get back on service because Medicare, the whole point of the hospice benefit is to keep these terminally ill patients out of the hospital and to keep those medical bills down for Medicare. And so if we have someone on hospice and then Medicare receives a $10,000 hospital bill and then receives another hospice bill a month later, they're going to start looking and see if there's some fraud going on. So we have to be real careful. But just know it still is always your choice, whatever you do, whether you leave the hospice, go to the hospital, revoke, change your doctor, change your nurse, that's always your choice.
Thank you. Another question is, how has hospice changed in the past 10 years?
Good question. So let me think about that one a little bit. Hospice was founded in the 1980s, and a lot of it happened in the hospital. Not a lot of knowledge around it. Again, talked about hospice being a scary word. Up until about 2000, it was terrifying to hear the word hospice because it meant that someone's going to die real quick. Over the last 10 years, I think people have become a lot more accepting of it. They're on for a longer amount of time because a lot of people aren't afraid to start hospice sooner. Again, if you have a terminal illness and you meet that criteria, then as soon as you decide you don't want aggressive treatment and you don't want hospitalization anymore, then you're appropriate to start hospice. We've had patients that are on for a year or more, sometimes as long as they continue to meet that criteria. I think that really a lot of the changes have occurred more behind the scenes with Medicare regulations and things like that. You used to be able to send your loved one to the hospital to a palliative unit to receive care in their final days once they were imminent. Like, for example, if you didn't want your loved one to pass away in your home, you could send them to the hospital, and that happened in the hospital under hospice care. They don't allow that anymore. There is what we call a GIP, a general inpatient, where if we can't control the symptoms at home, then we can send them to the hospital for some controlled symptom relief. It's very, very rare that happens. We used to be able to do that for imminent status patients, but they won't allow that anymore. They now have hospice houses. So it looks like a hospital in an inpatient unit, but it's just simply for hospice. So your loved one can go to a hospice house if needed, if they live at home and you can't care for them at home and they don't have a nursing home or somewhere to go. I think that's really it. I think in the last 10 years, things have been pretty much the same outside of the regulations.
Thank you. How can hospice help with family members who are in denial of the loved one's conditions or prognosis? How can they help with that?
That is our expertise and what we thrive on doing. It takes the entire interdisciplinary team, and every single one of us will work with that family to kind of help get them where they need to be in their own time, depending on how aggressive we need to be about that and how much time we have to get them to really see reality and what's going on. But that's where the nurse, chaplain, social worker really step in, wrap your family around, and help guide them and educate them. It's if we need to make daily visits, we'll make daily visits. If we need to come twice a day, whatever we need to do to make sure the end goal is we never want someone to take their last breath until the entire family is prepared and ready to be at that bedside to say goodbye and let go of their loved one. And that goes the same with family dynamics. Oftentimes we'll have brothers who haven't talked in 20 years, and mom is not going to take her last breath until she knows her boys are going to be okay. We really facilitate, bring the family together, and help figure that out. That's very much a huge part of hospice care.
We have a new comment. It kind of ties into another question I have. I'm going to read the first question and then I'll read the scenario along with that question with it. So they kind of tie together. How can hospice benefit people with advanced dementia? And so here is a scenario that I feel like kind of ties into that with their question. I have an elderly father that does not currently comprehend well the word hospice itself elicits alarm as he understands hospice to be end of life. Is there a way around using the word hospice itself with his care? Is there an alternative to that?
Yes, absolutely. We do it all the time. So the biggest thing with dementia is, they're not fully present, and so the word hospice definitely does scare them often. And so we really do try to avoid to use the word hospice with our confused or altered mental status patients. It doesn't mean that we're 100% successful because we don't ever want to either lie to someone or hide something. If they have dementia and they are not their own POA and they cannot make medical decisions for themselves, then we definitely can completely avoid the word hospice. We don't need to tell them they're on hospice. We really like to use the words where you're caregivers, we're coming to give you extra help. There's lots of verbiage around having to use the word hospice. A caveat to that is our clothing says hospice, our name badges say hospice, some of our cars say it. So sometimes it is a little bit challenging to be 100% successful with that. However, on the flip side of that, we do have families sometimes that will say, my husband was diagnosed with cancer and he's not a candidate for anything and the doctors won't do anything about it. They're saying he needs hospice, but I don't want him to know. That's different. If they're alert and oriented and can make their own decisions, we absolutely make sure that they understand that they're on hospice care, what it means, and that it's their decision. But dementia is a completely different realm, and we definitely will work with families around that word for sure.
So would maybe like daily life care be a good alternative for a description? If
Anything that family thinks would make their loved one most comfortable. Paid caregivers, nursing care, home health care, really anything that would make them more comfortable would be appropriate because they're not, they're in a delusional state of thinking. And so the right terminology really isn't necessary at that point. It's not really considered lying to them. As long as we're using integrity and it's in their best interest and the family is on board and it's what the family wants, then we can definitely do that.
Thank you. I think that is it. Just kind of one comment on our last scenario with the father, within the stigma around the word hospice. Before I came to OU, I used to work at Touchmark. It was a retirement center, also had a memory care facility, and I was specialized in the memory care facility. And before I worked there, I didn't really know much about hospice in itself because that wasn't my specialty area. And I can say after my time of working in a facility and having hospice, various hospice vendors come through, it really changed my perspective. And I saw it as a way to enhance that person's life in that current stage. So I just wanted to share that along with maybe I would also call myself in the memory care facility, depending on the person, for that caregiver or whatever the task is I was doing. I was either their best friend, a housekeeper. It kind of had to shift based on that person's perspective. And so I can't for sure say with your father where he's currently at, but sometimes you have to shift where you're not lying, but it's something they understand and can connect with that doesn't scare them.
That's a good point, Kaylee. We actually have a home health aide right now She's our only home health aide that can get this certain individual to take a shower. They've tried the facility staff, family, and this one person can get him in the shower, and he knows her as his chaplain. She's a home health aide. She's not a chaplain, but she prays with him, she talks to him, and she just goes right along with it. And he feels like he's getting a chaplain visit and is willing to get in the shower. So sometimes whatever it takes to make them comfortable is definitely okay.
Does anyone have any other questions? If not, I will wrap this up and make sure I get the handouts to you along with any links to helpful resources to you all. I'll give just a second.